Good evening, everyone, and welcome to the Canadian Society for the Advancement of Gynecologic Excellence online education. And this one is Ask the Expert, Medical Management of Uterine Fibroids During the Pandemic. And we have, my name is Nicholas Leyland, and I work at McMaster University. And we'll be having as our experts Tim Strand from Memorial University and Liane Belland from the University of Calgary. So just some housekeeping things. I want to thank everyone for joining us for this session this evening. And we'd like to thank also AbbVie for supporting the CanSAGE online education, and CanSAGE and the administrative technical support. So Lisa Lepowski and Morel Fosson. Tonight, it's going to be case presentations, and the objectives that we're looking at the end of the completion of this session, the participants will be able to reflect upon the impact of COVID-19 pandemic on the care of women and symptomatic fibroids, to really understand the investigation of fibroid and fibroid symptoms, particularly during the pandemic, but there are many, obviously, similarities between outside the pandemic and what we're experiencing now. They'll be able to discuss the role of medical management of uterine fibroids, fibroid-specific medications, and symptom-specific agents. We need to really think about the fact that many of these patients are presenting with symptoms, so we want to deal specifically with fibroids, but also we need to remember that many of them present with other symptomatology, including concurrent endometriosis and abnormal bleeding, so they need to be worked up appropriately for those issues. And lastly, to understand the management of symptomatic fibroid during the surgical delays due to the pandemic. And now I'd like to hand over to Dr. Tim Strand, who will begin the case presentation. There will also be some polling questions that we'll bring up, and we'll get you to contribute to the session by filling out the polling issues. So welcome, Tim, and the floor is yours.
Thanks very much, Nick. Welcome, everybody. And we drew straws and it decided that it was age before beauty, so that's why I'm going first. And notice the low lighting, because the age is not always very kind to the high bright lighting, the LEDs. So welcome. My privilege to be with you this evening to kind of talk a little bit about a couple cases. These are actual cases. We haven't highly edited them for the presentation tonight, but we'll hopefully spark some discussion as we move forward. Just a disclaimer slide that I've got some research grants on the go and done some consulting with different companies in the area of women's health to help with women's overall care. So this is our first patient, pretty typical presentation in my practice anyways, and hopefully in your practice as well. You probably see someone similar to Lori. This is not a real name nor her real picture. Lori is a 40-year-old. She hasn't had any pregnancies. She lives in a small community in Labrador. And there's obviously some remote issues when we're dealing with people that are at different centers that are some distance away. And she presents with very heavy menstrual bleeding. Her symptoms include flooding at night and with pad changes overnight. But also, in addition to that, she had irregular bleeding as well. She's passing very large clots the size of loonies. I tend to ask in terms of, I don't know, some people use fruit, I use coinage when we talk about the size of clots, and that's something that patients will sometimes relate to. Although she doesn't have any bulk symptoms at all. And we're talking about our management of fibroids. Obviously, it's fibroid talk. We kind of got the diagnosis before we get the full presentation, but she certainly doesn't present with bulk symptoms at this time. Lori doesn't have any plans for pregnancy, and her partner's already had a vasectomy. Her BMI is 40, and that's not atypical for my patient population in Labrador, but didn't really enter the management in Lori's particular case, and we'll see that as we move forward. She did have an appropriate abnormal uterine bleeding workup by a gynae colleague who saw her initially from consultation from her family doctor, which included, of course, her CBC, a ferritin, a TSH, appropriate cervical and endometrial sampling. She had a Mirena inserted and was expelled shortly thereafter. So you start thinking, you say, well, why did she have an expelled? Did she have a molar abnormality? Did she have something else in her cavity to cause the expulsion of her Mirena? Or was it related to the heaviness of her bleeding at the time? Again, this is not a true picture of her particular Mirena. Got to laugh sometimes, right? So her referring gynae had performed a hysteroscopy to find out a little bit about why she had the expulsion of her Mirena, to find out if there was an abnormality in her cavity. And at that point in time, the dictation read that she had a submucosal fibroid. There wasn't a comment of size at that time, and it didn't really say whether this is a type 0 or type 1 or type 2 submucosal. But because of her quality of life issues, she was started on ulipristal acetate. Just to control her bleeding, because again, remember, she didn't have any bulk symptoms. She was switched to Lupron shortly thereafter, after discussing the case with me. And partly the reason we switched it off of the ulipristal acetate was, I don't know if some of you remember, but sometimes people that were on ulipristal acetate, if you're planning for hysteroscopic resection, which was eventually our plan for Lori, that sometimes your fluid management during the procedure is very difficult to manage. So sometimes you get quick absorption of a lot of fluid of glycine at the time and not allow you to continue the procedure. So we actually had planned to switch her over, but then with the recall of UPA, it was another reason to switch her over to Lupron. And her plan was for hysteroscopic resection of her fibroid and roller ball ablation, because she wasn't planning any more pregnancies at that point in time. And it felt at the time that because her cavity was so large and wasn't planning any pregnancies, that the fibroid may not be the only reason why she had heavy menstrual bleeding, so treat at the same time. That was our plan. So if we can bring up the poll. Great. So so we started on Lupron. So in this scenario, what action does Lupron have in this scenario? So we've got improved quality of life by decreasing bleeding, improve anemia preoperatively and planning for an operative procedure, decrease our fibroid volume prior to surgery, decrease fluid absorption at the time of surgery, or E, all of the above. If people want to go ahead and answer the questions, and I'll get the results then. Great. So the good news is that even though this coming back as all French results, I don't know why it came back as all. Oh, we're going off again. Lisa's going to see if we can get an English version of the results. Excellent. So yeah, the correct answer is that none of the answers are wrong. So they all contribute. So, and this is really important when we're doing, especially we're doing large fibroids, is that, you really want to decrease your fluid absorption at the time of surgery. You know you're going to use more fluid. And even for people that don't have a large fibroid, there's been a Cochrane review that if you give the GnRH prior to surgery, you'll decrease urine volume, but also you'll decrease your fluid absorption at the time and make it easier for you to complete the surgery in a timely manner without the fluid balance issues. And so that was our plan until COVID hit. So COVID hit Newfoundland, Labrador. We were late. We were last in the group. It's kind of went from BC out to our way. And so we said, well, let's keep her on a little longer because we're waiting for a surgical time, et cetera, like most of you were. So she was maintained on Lupron, and we added Advac. And Advac was basically to control her vasomotor symptoms or tolerability, but also quality of life at the time. And of course, depending how long she's been on it, to prevent her bone loss. And so she eventually got to the operating room, and at hysteroscopy at the time, she's got a little bit bigger fibroid than we kind of expected. She had a 4-centimeter type 2 fibroid on her posterior wall. So when we're doing these large fibroids, and just to kind of takeaway of how I like to approach it in my training as I've gone along is to not just keep whittling away at it, but try to keep it in quadrants. So start on your left side, do slow passes. Once you finish a pass, make sure that that pass is hemostatic before you move on the next pass, because you don't want bleeding to obscure your view, because view is always an issue when you're doing these large fibroids. Watch to see if make sure you have coagulation at the end of each pass. And of course, you're watching your fluid balance. Of course, even though we did all these preventative measures for Lori ahead of time, she ended up during the procedure, and we weren't finished the procedure, weren't able to finish it in a timely fashion. She ended up having a fluid deficit of 800. So we stopped the procedure, checked her lights and recovery, and her sodium was normal at 139. So then Lori was brought back a month later, and her hysteroscopy showed a type 1 4-centimeter fibroid. So what is that? Well, you can imagine that as the fibroid is shelled out or shaved smooth with the cavity, and the uterus doesn't like all this energy that's being delivered to it, the fibroid will actually deliver itself into the cavity. And then you go from a very smaller fibroid to more like a type 1 fibroid, where your angle of the fibroid to the uterine cavity looks more like a type 1 rather than type 2. We were able to complete her myomectomy and then her roller ball ablation at that point in time. Fluid deficit was perfect. And then, of course, with COVID, we followed her up virtually back in Labrador. She had very light monthly spotting and felt really well afterwards. And I think that's the end of that case, Nick.
Thanks very much, Tim. That's a very interesting case. Just to remind people, if you do have concurrent questions, put them into the question and answer or even the chat, and we can address them as we go along. We did get a number of questions before starting tonight, so I will address that after we talk about the cases, and we can address any of your questions and those questions pre-submitted at that time. So, Dr. Belland.
Hello. Okay, let me just share my. Bear with me. Apologies. I'm just going to get. And here we go. Can I just verify that this is sharing, Dr. Leyland?
Looks good.
Okay, fantastic. Thank you so much, everyone. Thanks to CanSAGE and AbbVie for having us tonight. This is absolutely a fantastic topic. I know everyone's zoomed out, but it's really nice to see virtually that everyone has made the time to join us. So as Dr. Strand talked about with regards to uterine fibroids, there are a variety of different ways that our patients are now presenting, always have presented, but specifically now are presenting with uterine fibroids during the pandemic. There have been a number of different challenges, either delays in presentation to the emergency department through fear or through potentially restrictions, so that in my experience, we've seen a variety of shifts in those clinical presentations. So what I'd like, for those of you who know me, you know that I absolutely love food. If I wasn't doing gynecology, I'd probably be a chef. So I thought I'd present you a duo of fibroid presentations in pandemic times. And this is to highlight really the fact that fibroids can look the same, but can present in very different ways. So what I'd like to present to you are two different patients side by side. That the first is IL. She's a 39-year-old nulla gravida. Again, very common theme from Dr. Strand's presentation. She presented to the emergency department in January of 2021. She had significant abdominal pain. That was the reason that took her to the emergency department. And on presentation, the emergency doc astutely figured out that she was in urinary retention and promptly put in a Foley catheter that drained over 1.5 liters of urine. On a detailed history by the gynae resident on that night, it was noted that fertility was a non-issue with this patient. She was otherwise healthy. She had no prior surgeries. She was absolutely a small woman with a BMI of 19. So a little bit of a difference from what was presented by Dr. Strand. She had had heavy menstrual bleeding, but regular menses. She did endorse clots and flooding as well. She was hemodynamically stable in emergency. Hemoglobin was 74 grams per liter in emerge. She had an MCV of 69 and a normal creatinine. She had imaging that was done. I'm sorry, let me take a step back. She had a physical exam that was done and the uterus was palpable to the diaphragm. We have access to a provincial computer system here called NetCare. And so the resident very astutely again went to see if she had a history of fibroids. She had a prior ultrasound from 2018 that showed a fibroid of 8.8 by 7.9 by 8.5, and it was described as posterior with no further detail. So I'm just going to switch over and contrast this to another patient, NR, who's a 51-year-old, again, a nulla gravida. I don't know why I can't seem to present multiples, but she's another nulla gravida. She was actually seen in the office in July of 2020 with an enlarging uterus. The family doc was very concerned and actually pleaded a case for her to be seen in person. She had known fibroids since 2004, but had had some sporadic imaging throughout. She complained of intermittent bulk symptoms, mostly through urinary frequency and actual complaints of bulk. She had irregular menses without vasomotor symptoms. Shockingly, she had never had a pap smear in her life, never had an endometrial biopsy, was otherwise a healthy woman who, at the time I got the sense that she just didn't like accessing healthcare. She had no prior histories. Her BMI was 17. So it's apparently the competing BMI of lowering BMI. Her hemoglobin was 168. Ferritin was 27, which greater than 20 is normal for our reference range here. Her uterus on palpation was 26 weeks. She had zero movement on this abdomen. Her uterus was absolutely full. She had a pelvic ultrasound that had been done in June of 2020, just prior to her coming in, and it showed a uterus in 3 dimensions measuring 24 by 11.8 by 20 centimeters. She had no hydronephrosis, and ovaries were entirely normal on that imaging. So what I thought I'd do is combine these two, because I'd like to show you the importance again of going back to imaging and having a look. The imaging that I'm going to show you could belong to either of these women, but it does actually belong to NR. So here we are. This is an MRI that was obtained on admission. I'm sorry, I said it was NR, but it's actually IL. The uterus here on an MRI was measured at 28 by 10 by 11 centimeters. They actually provided us with beautiful phagotyping showing type 5s, type 2 to 5, type 6, and a type 1 of varying dimensions seen here. Ovaries were normal. Again, on MRI, she had moderate hydronephrosis. So I've always loved when Dr. Singh always says, look up, look up. And I think that's a really good way of remembering. On imaging, we can never forget 2 things. One is, are we looking for additional pathology? And the other is the pathology that we're seeing causing any compromise from the genitourinary tract? So it's always a very good idea on your ultrasounds to rule out hydronephrosis, be it if you are looking purely at fibroids or fibroids in association with another pathology such as endometriosis. And so when we get to the point of seeing these 2 women with massive fibroid uteruses, is it uteruses or uteri? I'm going to say uteruses. One of the things that I find very helpful is for us to always come up with an issues list, a problem list. It's what our internal medicine colleagues do. And I think that it's very important to kind of ground us in terms of what is the most important. So I'm going to break this up a little bit. IL came in urinary retention. So that was really our first important problem that we needed to address. She had a Foley catheter that was placed as we decided how we were going to get her out of this mess. And so she had a Foley catheter that was inserted. It was left 1 to 2 weeks while we initiated medical management. We wanted to correct her anemia. So in terms of what is life-threatening here, well, we needed to get her out of retention and we needed to correct that anemia rather quickly. We were thinking, of course, two things. One is the initial anemia correction. The second is preoperative optimization. So we gave her IV iron sucrose. She was admitted, she was given IV iron sucrose. We gave her 3 infusions while she was in hospital. Alternatively, for those who are very fortunate, you could do a single dose of iron isomaltoside, which would be fantastic. We just don't have it available to us in Alberta on formulary, particularly at that time. And then the third issue with IL was really, what was our long game? How was it that we were going to achieve what we wanted to achieve? So what we started her on was a GnRH agonist. We chose Lupron 11.25 while she was in hospital. Fortunately for us, she was in her late luteal phase. So it was almost like, you know, the stars aligned for us to inject her with Lupron. So ADBAC was started with norethindrone acetate, and which, you know, we can talk about sort of the layering of that with regards to addressing vasomotor symptoms, but also addressing the impact on bleeding as well. She had a repeat hemoglobin on April 21st. Hemoglobin is now 100. Her ferritin is 15. So, you know, we're gaining. We're not gaining as quickly as we would like, but we're gaining. She's booked for a laparoscopic hysterectomy in July. I'm hoping to get her IV iron repeated prior to the OR. So that's where we've parked our first patient. Our second patient, which is NR, her issues list was really a preoperative workup. So remember that I had said that she'd never had a pap test, never had an endometrial biopsy, yet had irregular menses at the age of 51 with a massively enlarged uterus. So many issues there. And it's one that Dr. Leyland mentioned at the beginning, is really never, ever to forget that we need to do our due diligence with these women that are coming in with fibroids. We can't just put the blinders on and forget the basic things. We need to rule out malignancy, both at the level of the cervix as well as the level of the endometrium. In a 51-year-old with a massively enlarged uterus, you also have to give consideration to the possibility of a malignancy. Despite the fact that an endometrial biopsy does not have the sensitivity that we would like to obviously preclude the possibility of a leiomyosarcoma, it is possible to get lucky on an endometrial biopsy with a leiomyosarcoma. So it's really important that we include this as we think to downstream operative intervention. The second issue was bulk reduction. And again, what we were thinking of is having that ability to perform a minimally invasive surgery, or at least, you know, give me room to put a camera in and we'll figure out the rest. The patient needed reassurance with regards to GnRH agonist. She is someone that had not accessed healthcare on a regular basis. And so she really was quite leery of using a GnRH agonist, but we really supported her in ensuring that we would cover her with regards to side effects. A variety of different ABBACs could be used if she needed that. So again, we started her Lupron. We had the benefit of timing. We had brought her for the hysteroscopy DNC. We had a PAP that was benign. We had an endometrial biopsy that was benign. We had a massive uterus. We waited for a luteal phase. We injected her with 11.25. She was given a prescription for norethindrone acetate, which she started immediately. Remember, she's a BMI of 17, so she's not getting a lot of estrone production. And so she started hot flashing right away, started her norethindrone. She still had hot flashes following 5 of neta. So I added on 0.5 of estrase, and that really controlled her hot flashes nicely. We just did her laparoscopic hysterectomy on May 6th. So this is hot off the press. She had reduced, again, expectations with the 26-week size uterus is you know, we need to keep those expectations realistic. We're not going to get a 12-week size uterus out of that. But we had enough fibroid volume reduction to about 24 weeks where we could get Palmer's point insertion. We got our ports in, we did suprapubic morsellation, and it came out a monster at 4,665 grams. Significant degeneration, no malignancy. She went home the next day. Post-op hemoglobin was 90, but that's really not the important thing here. The important thing is that we were able to medically manage her to get her hemoglobin preoperatively. Her hemoglobin was in the 120s and 140s, I'm sorry. And post-operatively, what's important here is that she didn't get any transfusion. That's really what we were aiming for. Our blood loss in the operating room was 800, but we always have to guide our patients as well in that she lost a lot of blood in that massive uterus. So that's really the important thing. So I've just got a few different questions here with regards to some of the medical management finer points that I've brought up. Is what do you currently prescribe when administering Lupron or other GnRH agonists out of phase, meaning not in the luteal phase? So if you're having to administer them without knowing where they are, either through irregularity of the menstrual cycle or someone who just doesn't know, are you using norethindrone acetate or Alyssa, either 150 or 200? Are you turning to letrozole or nothing? I just said, I just go for it. So if you could answer that, that would be really helpful. Perfect. So this I would expect, and it's wonderful to see that people are drawing on a variety of different things. So everything from maybe just saying, you know what, we'll hope for the best and administer out of phase, to using letrozole, which has been described. It works very, very well, either 2.5 or 5. You can pick the number of days that you want to use it for. And then, of course, using Alyssa has probably been a really good addition. And I've used that in a number of patients where they were out of phase. We wanted to initiate GnRH agonist imminently, but we didn't want the flare and the flare bleed, most importantly. So Alyssa, I've used 200 single dose. You could use BID as well. The important thing here is that with the GnRH receptor antagonist, you're not going to get the flare that's associated with the agonist. So that's fantastic. Add back. So sorry, Lisa, there we go. Sorry about that. We've got another question here for polling. It's what do you currently prescribe for add back when administering Lupron or other GnRH agonists for uterine fibroids? Norethindrone acetate, no add back at all, esterase permetrium, or norethindrone acetate esterase, which is also known as Activel. And so the majority of folks are either using norethindrone acetate or norethindrone acetate in combination with esterase, and Activel. A few folks out there are using esterase and permetrium. So what's really interesting here is that the majority of people are giving add-back therapy. And I think, you know, this is one of the discussions that actually we as a group with Dr. Strand and Dr. Leyland have discussed is, you know, I think that the tide is really turning with regards to using add back when the indication is uterine fibroids. We recognize that as our surgical wait lists get lengthier and lengthier, that we're using our GnRH agonists longer, meaning that if our patient isn't comfortable with the first injection, they're really not going to be very happy about agreeing to a second injection. So it really comes down to our patient's quality of life. I do want to bring you to just one paper that was published that states that, again, small study, 51 people where add-back was used in uterine fibroids. They were randomized to progestin only without GnRH add-back agonist, with a GnRH agonist. So what they showed was that when you used a GnRH agonist treatment for 3 months and then looked at estrogen, progesterone, that there was actually no growth in uterine fibroid volume, as opposed to maybe looking at progestin alone, where there was a little bit of growth. So that's where a lot of people had that hesitancy initially to use AdBac when it was used with uterine fibroids. So I will stop here and send it back to Dr. Leyland.
Thank you very much, Liane. There are a couple of questions, or there have been in the chat. One is that you have addressed specifically about AdBac therapy and the timing of it. So can you just explain the reason for the late luteal phase injection, if you can identify that?
Sure. I mean, it's nice when the patient comes in. I mean, we really lucked out, with the patient that I presented. Number one is that the patient had, regular menses. So identifying the luteal phase was a little bit simpler. The reason that we want to use a late luteal phase, or even a luteal phase administration with a GnRH agonist, really relates to the fact that with the GnRH agonist, you're going to get that flare. So initially it's turning the tap the wrong way. You actually get an increase in the GnRH pulsatile fashion. You get an increase in LH-FSH, and therefore you get a large increase in the serum estradiol. So, which can, of course, either exacerbate bleeding, which is oftentimes what we don't want when we're administering Lupron. So, giving it in that late luteal phase, it's when that FSH and LH are at their lowest. It's when that estradiol, everything is coming down. So even if you have a bit of a flare, a little bit of a blip, the patient is going into her menses where things are proceeding down. So even a little bit of a flare is unlikely to cause exacerbation of their symptoms.
Yeah, so it's really important. I had to learn the hard way, as people did when we first started using these agents in the 90s, about fibroids and bleeding and the flare effect. So if somebody is on the birth control pill, that will suppress them as well, or other agents, anything that will suppress ovulation. So, but it is very important, obviously, if we're trying to get patients to the operating room to try to normalize their hemoglobin. I think there's another question here. Somebody is asking, which reason do you prefer Neta as AdBac rather than estrogen progesterone?
I mean, I think for me, it's comfort. We're used to Neta. It's one medication rather than two medications, and compliance is sometimes an issue with this. And I approach it similar to how Liane does as well, that I'll start with Neta. And if they're not symptomatically controlled at that point in time, add some estrogen in addition to it. But it's just ease of prescribing it and ease of actually the compliance. We used to do all kinds of funny 2 days on, 2 days off in terms of progesterone for long-term endometriosis patients. But I think, compliance is an issue for any medication. But if it's one medication versus two, that's the only reason I would use Neta versus estrogen and progesterone. Liane?
Yeah, I would also go based on their history, how they've responded to different progestins in the past.
Sure. Yeah.
So if they've struggled on different progestin formulations in the past, I may shy away from a norethindrone acetate. I may be more apt to use, the esterase and even a prometrium.
Yeah.
So I'll split it up. It's really dependent on what they're coming to us with. If they're neither here nor there and they've never had any mood issues or any side effects with prior progestins, I would certainly go for norethindrone for all the reasons you mentioned, Tim.
Yeah, it really depends on the patient in front of you and their story. You're right. Yeah.
Mm-hmm.
Yeah, so basically, I mean, norethindrone acetate was, noralutate was the most evaluated AdBac therapy in the late 80s and early 90s. And it doesn't make a lot of sense because it's just progestin, but there are estrogen metabolites that actually do protect the bone and minimize vasomotor symptoms. But there are lots of different options. And again, it depends on the patient and the response in terms of ameliorating symptoms. There's another question in the chat. Not sure if you addressed the question to Dr. Brill, who asked the question about would Lupron in the late luteal phase not increase the risk of heavy bleeding? The one important thing to remember is that there will be bleeding. They will get one more menstruation, but what we're trying to do is not stimulate the endometrium. And if you do give it in the late luteal phase, you're not going to get the flare, which is the increase in the estrogen to the point where they're going to have heavier bleeding. So that's the rationale behind that. Just monitoring these questions. We do have a question that was actually given to us beforehand. Maybe you guys could address this. Is anyone still using morsellators to remove myomas?
Yes, with a careful discussion.
Electric morsellator or morsellation?
Some of each, right? Mostly we'll use some morsellation. I think it comes down to a careful discussion with the patient and what are risk factors. And I have kind of a case a little bit around that if we need some kind of time to go through that. But I mean, the whole issue of uterine sarcoma, they are rare. But if you manipulate a uterine sarcoma, there's, are you preventing any spread, whether you do it in a bag, whether you do it outside of a bag? If a fibroid that looks like a fibroid, and you can be somewhat reassured by its response to medical therapy, careful discussion with the patient that this may be a sarcoma, and it may spread and you may seed it. Occasionally I will still morsellate, either with mechanical or otherwise. And I don't think if you use you probably spread a bit more with mechanical, but I don't think you're really reassuring yourself, in my opinion, by using some other form of morsellation. If you're going to cut it up, you're going to cut it up, and you're probably going to spread things if it is a sarcoma. And that's the cowboy method of cowboys planted in Newfoundland method of doing things.
Do you have any comments, Liane, about that?
Yeah, we actually haven't been able to get we haven't used them for 5-6 years at least. We don't even have them in the hospital. So we decided, when all of this was breaking in the US, and even prior, I think, to Health Canada's sort of disclosure on all of this, we decided as a site that we just weren't going to purchase them. I have to say that I wasn't using a lot of electromechanical morsellation prior to that. I think the morsellators that I have are my two hands, and that's really all that I use. We either use Inbag if we can, and I will say that with the case that I presented with that very large uterus, nobody did the dance of joy more than me than when I got the pathology. So even though we can do all the due diligence in the world, I think that ultimately, until we have that pathology, there's always that feeling of unsettledness. Leiomyosarcoma is never what we want for our patients, but I haven't used an electromechanical morsellator for eons.
Yeah, I mean, most of the ideal case for me would be somebody who's post-ablation syndrome, who doesn't have a fibroid, who's had endometrial sampling prior to that, and she's got a tiny little uterus, and you want to do a subtotal on her. And I have a reusable device. That's probably the only people that I'm commonly using morsellation for, because it's a nice procedure. They get home the same day, and there's no incisional pain type thing. So that's where I use it most often.
It certainly has evoked a lot of controversy over the last number of years, and so we do tend to try to use in-bag morsellation either for hysterectomies through the vagina or suprapubically. I would imagine that the second case you had would have been a significant challenge to get into a bag, let alone morsellate. So I think I would agree with Tim that it is about fully informed consent and a discussion with the patient and engaging them in that process. Tim, you have another case. Did you want to present?
Sure, I
that
can go through that. Yeah, it kind of jumps off from where we left off. So
Okay.
I'll just go ahead and share my screen. So this is a case. So again, this is not Gina's picture. Gina's a 45-year-old, and none of these patients got pregnant. I don't know what we're doing, Leanne. I think we got out of the fertility business too early. But she was known fibroids. She presented with bulk symptoms. We did a hysteroscopic myomectomy on her about 10 years ago when she was 35. She didn't know her pregnancy plans at that point in time. So we just did the hysteroscopic myomectomy. I think it was like a 3 centimeter type 1 or type 2 for abnormal uterine bleeding. And now she's come back and her bleeding is well controlled, but she still has these bulk symptoms. And they included overactive bladder and some bloating symptoms as well. And she has no plans for fertility at this stage. And that's good to hear from, sometimes our 45-year-olds want to come in and say, yes, I want everything done and I'm going to get pregnant if you do my myomectomy on me, but this was not her plan. And we examined her, which is a good thing to do before we image her, but we examined her and she's got a really irregular fibroid uterus and 2 centimeters above her umbilicus. Ultrasound showed a multifibroid uterus, largest being 6 centimeters, which was posterior. And we discussed different options with Gina. And she had preoperatively for fluid absorption before, she'd had Lupron before and tolerated it well. So she elected for Lupron for symptom control in terms of her bulk symptoms. And we did add Neta because we expected her to be on it for some period of time, as well as for her compliance and tolerability. So Nick got into this earlier. I mean, you really have to look at the patient in front of her, and we're treating symptoms. We're not treating, disease states, right? So she was maintained on therapy for 3 months, but really started to have what seemed to be more GI upset. And in, talking with her, we really kind of went down the road of IBS with her, and she got worked up for her family doctor, had appropriate workup by GI specialist, who really hadn't done much in terms of IBS treatment for her, just ruled out other pathology, not surprisingly, in our center anyways. And she had really constipated related IBS. And I had a few patients that come my way with this kind of constellation of symptoms. And I've started her on some Constella, which basically it works only on the gut. It adds water to the gut, and it can add too much water to the gut. So you have to be careful of the timing of taking it. But she actually did very well. Comes in 2 different doses. Sometimes you have to play around with the dosing a little bit for your patients with constipation related IBS symptoms were really quite well. So she did well from that kind of bulk symptoms, but then after a year of medical therapy, she said, what's the plan? Are we going to just kind of carry on as we are? And although she was doing well, but her hemoglobin was normal, she had a normal iron, but she was still having some bulk symptoms that weren't completely resolved by her IBS treatment. Uterus was certainly smaller, it was below her umbilicus, but she really wanted to know what her end game was. So we kind of talked about her options, and she had some normal pap smears just as a side. So Lisa, can you throw up the next poll? What you guys might offer her at this point in time. So, certainly you could continue on continued medical therapy. She could just take the largest myoma out, do a total laparoscopic, total subtotal hist. We talked about morsellation a minute ago, or an abdominal approach. If anyone want to put in their answers there, it'd be interesting what the group feels, what they might offer her. Or maybe there should be an all of the above. Yeah, so this MIS group, so they said laparoscopic total hist. And we talked about the options for her, and I don't think there's a right answer for this. And that goes back to, the patient that's in front of you. Lisa, if you can close it, or I can close it, thanks. As going through the options and whatnot, she starts to gives a story that she had this aunt with a history of unusual uterine cancer. And she doesn't know what kind of cancer it was. We just know it was an unusual cancer. And of course, we don't have any pathology arranged for her or go back to figure out what it was. So we talked about the low possibility of a uterine sarcoma, and I was kind of leading her down the road so we could do a laparoscopic approach for her. It's small enough, we can get it out through smaller incisions. You go back to work earlier. and issues of operating or even manipulating a uterine sarcoma in this situation. But with her discussion, she just said, you know what, let's do it through an incision. So I've actually booked her for a total abdominal hysterectomy. I think the booking clerk kind of fell over when I booked her, because I don't think I've booked a abdominal hysterectomy for, I don't know, 5 or 10 years at least. No, booked one. Sometimes you have to convert, obviously, but I booked one. And I hope I remember how to do it. Is it cut, then clamp, clamp, or is it clamp, clamp, cut? It's hard to remember all that. But that's Gina, yeah.
That's a great case. I think one of the important things that has been alluded to is preoperative preparation, and in particular, getting hemoglobins up with these agents to be able to reduce the risk of requiring transfusion, but also there is significant increase in morbidity and mortality in patients who are operated on when they're anemic. So it is a key issue to get the blood testing beforehand and to determine where you're starting from and where you have to get to for the operation. A question arose in the chat. It's both about letrozole. One is, would letrozole be effective for treatment of fibroids? And the second is, how does letrozole work to prevent flare?
I can feel the mechanism of action. So letrozole is an aromatase inhibitor, and so letrozole and aromatase inhibitors are far more common in the oncology world, particularly in the breast cancer world. They really target the end organ. And so what we're trying to do is actually to inhibit steroidogenesis at the level of the ovary. So what we're actually doing through an aromatase inhibitor is inhibiting that final step into estradiol. So what ends up happening is you can have the flare by giving your letrozole at the time or preceding your Lupron injection. What you're doing is you're really shutting down that ovary, or the ability of the ovary to convert all of the androgens into the estrogens. So through aromatase. And so you can then inject your GnRH agonist without the ability of the ovary to respond to that flare of LH-FSH. So the difficult part with letrozole, as we know from our oncology patients, and certainly from experience in gynecology, is that it can cause extreme arthralgia. They can get quite severe joint pain, and it's not really dose related or time related. It can start immediately with the first or second dose. So it definitely has a benefit. I've had as many people who didn't have joint pain as who have. It's really hit or miss. And could you use letrozole for the treatment of uterine fibroids? I certainly have, in patients that have not demonstrated joint pain. As a long-term treatment, I don't see it as being feasible in the sense of from the side effect profile. It's hard to titrate the amount of shutdown of that ovary. But having said that, there are definitely studies that have used letrozole in uterine fibroids and fibroid volume reduction. And our fertility colleagues actually use letrozole in a variety of different ways, from ovarian stimulation and all of that. So, oftentimes when I have used letrozole, it's with the aim of getting them to the fertility clinic and in that partnership.
It's not cheap though.
Nothing's cheap.
So let's see, questions. If Lupron is used preoperatively for 3 to 6 months, is AdBac still recommended to minimize hypoestrogenic symptoms? I think you touched on that earlier, but do you want to expand on that for this?
Yeah, I mean, you really want to, not just for compliance to make sure they still, but you want to make sure that they're actually feeling good. You're trying to improve their quality of life, right? So definitely for the hypoestrogen symptoms, I would definitely use it. If I'm considering, if I'm using, I'll sometimes use Lupron as a one-time dose for a rollerball ablation just to decrease fluid absorption 1 month prior. And I don't always use Advac for that. But if I'm using it for fibroid, if I think they need to build up their hemoglobin, if they're using it for a few months, I definitely use Advac right from the beginning. There's no reason not to, in terms of their quality of life and to stop those hyperestrogen and estrogen effects, right? That's the only time I will not is if I'm using one-time dose and I'm going to get from the operating room within a month. Right?
Thanks, Tim. There's another question, and that is, have you any experience with the use of mifepristone as treatment modality for fibroids? I mean, there is evidence that it is efficacious, but do you have any experience with that?
I haven't, no.
No, I don't. It's unfortunate because I think as a precursor to ulipristal acetate and in that category, yeah, it just makes sense theoretically. I do not have any clinical experience with mifepristone.
Okay. So I have been addressing some of the submitted questions, but there are some other ones. What about fibroids, heavy bleeding, and future pregnancy? Which fibroids would you manage and which would you not manage with respect to surgery?
I don't do fertility, but I don't do a lot of fertility, that is. But certainly, I mean, any submucosal fibroids that have a component to them, you want to be careful about using how much energy and making sure that you're shaving things flush and you're not disrupting or causing any Ashman syndrome. Ones that are type 3s to type 5s, I typically, I wouldn't recommend that for a fertility patient unless they're having huge bulk symptoms. And then there's a whole issue of delivery state, uterine rupture, full thickness myomectomies, that kind of stuff as well, right? So I don't do a lot of that in my own practice. Liane, do you see a...
Yeah, I would definitely, I definitely see a fair number of folks with this sort of scenario. I think I would precede this, Nick, by saying that I think two different things need to happen. One is absolute accurate mapping of the fibroids with phagotyping. So knowing whether you're dealing with a 0, a 1, a 2. As Tim mentioned, I think 3 to 5, the jury's still out, particularly in somebody who's unproven with regards to fertility. I think that you also need a cavity assessment, and, whether or not you have access to a sonohistogram or, an HSG, there needs to be some sort of cavity assessment, I think, before we would be able to weigh into a patient with regards to what that effect will be on fertility. If you've deemed that you're dealing with a 0, 1, or 2, and you are proceeding on to the OR, I think that we've had refinement in our technique away from either the use of monopolar or bipolar, even using MyoSure or non-cautery type approaches in the fertility group. I think that would be the indication to be using that. So where you can also get a specimen and you can minimize the thermal spread of the electrocautery device that you're using. So, I think that there needs to be a really good workup, assuming that you find a fibroid that has the potential for impacting fertility, whether that be spontaneous or through ART. I would definitely normalize that cavity and use it in the most non-traumatic way as we could.
Thank you. You alluded to sonohistography, and it would have been an interesting polling question, but access to that modality is quite variable across the country. And you also alluded to the importance of a cavitary assessment, which can be done in part by hysteroscopy as well. But one of the things I'm always concerned about is with the type 2 fibroids, how close you are to the exterior surface of the uterus and the risk of perforation during the resection. And I have been asked to review cases with the CMPA on those. So it does happen where bowel has been injured. So I think it's really important, if you are doing these things, to have some sort of mechanism to try to minimize the risk of perforation. either during the procedure or at least understanding what the risk is beforehand with appropriate imaging or assessment of the patient.
Yeah. And even down at the cervical level is too well. So if we're cutting fibroids around in the cervix and cervical incompetence, right, that's can be a real issue with some of these, you know, type 1s and type 2s that are low in the cavity, right?
Yeah. So, another question is specifically about GnRH antagonists. So Orlis has been available for us. We do not now have fibrostol available for more acute bleeding, and there are issues with availability and coverage for this across the country. But just putting that aside, what's your sense about the use of GnRH antagonists in the more acute setting for symptomatic fibroids?
Right. So, I mean, as you know, there's not an indication for symptomatic fibroids for Orlis or Laglex, but there are some studies.
Just to tell everybody, we're talking about off-label use, but there has been the study in the United States, and it is available there with respect to a higher dose and with add-back therapy.
Yeah, and it's a 300 twice a day dosing, which we don't have here. But I mean, it certainly makes sense that it's probably not quite as full suppression as we would with Lupron in terms of your estradiol levels, but it certainly would make sense. I haven't used it personally for fibroid management, but because you can prevent the flare, it'd be nice to you can start it earlier and start control their bleeding earlier than if you were just to go straight to Lupron or something like that. Now there are there's also some sperms in the pipeway as well. There's some studies ongoing with that, but I think they're stalling a bit. The last I heard it. Just because of all the issues that ulipristal acetate had.
Okay, and what is the evidence or your experience with the use of Visan treatment for fibroids?
I love this question. Oh my gosh. Now we're getting to my love in life. Okay. So I love them. It's not, I feel bad for the patients with endometriosis and fibroids, but you know, this is a very complex and difficult presentation to deal with because you have to pick a favorite. So unlike with our children, where we should never pick favorites, with fibroids and endometriosis, we kind of need to, and it really does come back to treating the symptom and not the pathology. And so if bleeding is the issue, we address the bleeding. If pain is the issue, we address the pain. The difficulty is when you have a combination of the two, and potentially you have a patient who presents with multifibroid uterus but has bilateral endometriomas. So in reality, what she probably has is adenomyosis with fibroids, endometriomas, and a stage 4 pelvis. So the use of Dynagest, I mean, recognizing that 20-30% of women have both pathologies, I think I would say, number one, that a detailed history here is absolutely key. And so focusing solely on the fibroids, I think, will only lead you into the depths of despair surgically. And so there is no such thing, as I'm sure that, you know, we preach to our learners each and every day, there is no such thing as a persistent complex hemorrhagic cyst. If it's persistent, it's not a hemorrhagic corpus luteum cyst. So if you see an endometrioma in combination on your imaging with a multifibroid uterus, really what we should be talking about is addressing the endometriosis aspect and trying to reduce the bleeding if that patient is anemic. The use of Dynagest has been, there are several very small retrospective studies that are out there that have noted anywhere between 20 and 30% improvement in bleeding overall, but these are not profoundly anemic women. So, and remembering these are all retrospective. So it's very difficult. Our data on using Dynagest solely for the reduction of bleeding, I don't think is well supported through our data. Not because we all haven't wanted to, because I'm sure that we all use Dynagest in the patient with dual pathologies. I certainly do. And to me, I always feel that in 80% of women, the Dynagest will do the job on the bleeding. Yes, we know that one of the major side effects of Dynagest is erratic bleeding that tends to settle down over time. You can certainly supplement that with even a Lupron to settle it down, or even double down on your Dynagest. So, a BID administration, for 1 to 2 weeks, and then bring them back down to once a day. So, there are lots of ways to address the bleeding on Dynagest, but I think it's an amazing way to tackle two pathologies and hope that you get resolution of the bleeding from the fibroid end. I'm not always convinced that these are fibroids. I'm not going to lie. I don't really trust the imaging at times. It's very difficult to interpret. I'll give it that. But I often think that these women actually have three pathologies. They have fibroids, adenomyosis, and endometriosis.
Well, why wouldn't you use just Lupron in those patients then, rather than Bizan?
Yeah, sometimes it comes out of, I think that's a really good question. I think sometimes it comes out of patient preference, maybe drug coverage. It's again, it's sort of that granular flavor that you get where, they've tolerated progestins in the past. There's something inhibiting them, or you want to keep, it's kind of like poker. You always kind of want to keep something to throw in at the end of the game. And, sometimes you start with the easy things. Oh, sorry, I wasn't supposed to make poker references. But you always want to keep something. And, you start with an oral medication. It's a really nice intro. And then it does give you that sort of support if you need to go to the next level or to a next medication. So I would say there's absolutely zero wrong with Lupron because it will address both pathologies, but there's nothing wrong with using Bizan either.
Yeah, you're right. So some people, you're right. It's hard to get them to think about full suppression right off, to kind of say, we're going to start here, but we've got bigger guns if you don't respond, right? So this kind of stepwise approach, which is great for Orlissa, right? So we'll stop for, even for the endometriosis patient, we're going to start low and we can always ramp you up, but we got more to come if you're not doing well, if you're not responding to therapy. Sure.
Yeah, I don't even, sorry, Nick.
No, I was just going to say that we're just a little over time now, and there are so many additional questions. Somebody has just asked one last question here. If the patient has increased bleeding on a Lupron flare, will the addition of Netta help settle the bleeding?
I haven't seen it. I don't think. I don't use Netta for the flare. I think it's more just for symptom control.
Nick, I don't know what your experience. It's just something, unfortunately, that it's a time thing. Yeah, it's a time. I find, again, knowing where those fibroids are, I think are critical. I think if you have a 0, 1, or 2, sometimes you don't even get them dry on a GnRH agonist. You don't get them dry on a Lupron. So, again, purely with the flare, assuming they're not a 0, 1, or 2, you just grin and bear it and, just start atoning.
I don't think it would be very effective. Unfortunately, our time is out. I want to thank our panelists, Dr. Belland and Dr. Strand. I always learn something from my colleagues when we network like this. And you did a fantastic job. And again, we'd like to thank AbbVie for supporting the presentation, and also CanSAGE for the webinar format. So thank you very much. And thanks to the audience for participating, at least in the chat and the question and answering.
Thanks, everyone.
Thanks, everyone. Good night.
Thanks. Have a great night.
Dr. Leyland, I'm sorry I wore the same outfit as you.
I didn't get the email.